Okay, Bismillah ar-Rahman ar-Rahim. Today we are talking about the second part of the presentation regarding the analgesics. And as you know, the analgesics is very important topic. It is one of the triad of anesthesia. Triad of anesthesia consists of hypnotics, analgesics, muscle relaxant. And the important thing related to analgesics, that analgesics extended even after the operation for post-operative period, and also can be used in other than anesthesia, in the ICU, in the acute illnesses, in the many of acute emergencies. So it is very important topic and should be covered by all those who are working in the medicine. In this presentation, we will answer the following questions. Does the tolerance to opioid occur for its effect on all tissues? That is to say, the tolerance affects brain, heart, renal, or tissue functions, or part of them. Does tolerance to morphine show a reduction in analgesics response to other agonist opioids? For example, patient on morphine صار عنده tolerance. إذا نطيناه باثيدين تستمر التولرانس لو هنا الموضوع يبدي من جديد. Why pethidine is contraindicated in patient on MAO inhibitor, monoamino oxidase inhibitors? Are there gender differences in GABA opioid receptor effects? What is the relation of opioid and CA metastasis? What's the role of opioids in chronic pain management? Can morphine, fentanyl, and ketamine be used in neuroaxial anesthesia? Is there a role of analgesic indication of ketamine by oral route? All these questions gonna be answered throughout this presentation. And if there is any question missed to be answered, please alarm me. Regarding the history of opioids, Sir Turner at 1806 has discovered the morphus, and morphus is a plant, and opium is a Greek word meaning juice, or the exudate from the poppy. Opium is extracted from poppy seeds, يسموها paper somniferum. The opioid, يعني عرفنا الأوبيوم شنو، هسه نعرف الأوبيوid, is a natural or synthetic drug that bind to opioid receptor producing agonist effect. Means any drug or substance can produce the same effect as that of opium, named as opioid. This is actually the opium from poppy, and this is the fresh capsule without the exudate, and here the exudate. From this exudate, we can extract the morphine. So the morphine is natural from that of other opioids. Classification of opioids can be on different bases. If we talk about the source of opioids, can be natural opium, like that of morphine and codeine, or semi-synthetic, like that of heroin, oxycodone, or pure synthetic, like that of pethidine. And based on the receptor, we have agonist to receptor, like morphine, antagonist, like naloxone, mixed agonist antagonist, like that of nalorphine. And also we can classify according to chemically composition substances like phenanethrin group and benzoyl-isoquinoline group. Opioid agonist means activate some or all opioid receptor and do not block any. For example, morphine. Morphine is a pure agonist. Partial agonist, a drug that can activate opioid receptor, but the response is submaximal. For example, buprenorphine. Mixed agonist antagonist, a drug that activates some receptor subtypes and blocks some other subtypes, e.g. nalbuphine. What about a pure antagonist? A drug that blocks all receptors subtype, for example, naloxone and naltrexone. So we have 4 types of the effect regarding the opioids. We have pure agonist and pure antagonist, partial agonist, mixed agonist, antagonist. And we have 3 main important opioid receptors: mu, kappa, delta. The effect on mu receptor, supraspinal and spinal analgesia, euphoria, meiosis, sedation, constipation, respiratory depression, addiction, hormonal changes. And regarding that of kappa, also supraspinal and spinal analgesia, diuresis, sedation, meiosis, dysphoria, psychomimetic effects, respiratory depression, and constipation. And for delta, supraspinal and spinal analgesia. And as you see, there are some sharing effects. For example, supraspinal and spinal analgesia can be get through all the receptors, mu, kappa, delta, while some actions can be get just through one receptor. For example, here the diuresis just through the kappa receptor. Clinical uses and indications of opioid mainly and famously as analgesic, but can be used for cough suppression. All of us have been taking syrups for cough suppression. These syrups contain either codeine or dextromethorphan, and also anti-diarrhea, diphenoxylate, widely used as anti-diarrhea. In acute pulmonary edema, it is famous and widely used, the morphine, as one of the lines of management of pulmonary edema. And in anesthesia, the fentanyl is commonly used for intraoperative analgesics. Opioid dependence, to treat the opioid dependence, commonly they use the methadone as a drug of choice to manage opioid dependence. The effect of opioid on central nervous system can produce the analgesia, the mood changes, and other changes regarding the consciousness level according to the dose and may lead to coma, respiratory depression, nausea, vomiting, cough suppression, meiosis, hypothalamic effect, changes in temperature, producing hypothermia, and neuroendocrine effects like vagolytic and diuresis. All these effects can be gained by the effect through the central nervous system. Regarding the GIT system, we can get constipation, increased GIT smooth muscle tone, generally causing colic. And specifically for the biliary tract, constriction of biliary smooth muscle, which may result in biliary colic that not relieved by hyoscine. So better to avoid the opioid in the management of biliary colic pain by opioid, and we can use other types of analgesics. And regarding the renal system, an increase in sphincter tone may precipitate urinary retention, especially in post-operative patients. And for urethral colic by a renal calculus may be made worse by opioid, may be relieved by hyoscine. So this is another worsening of pain after that of biliary tract, worsening of urethral colic pain, and better to avoid the management of that pain by opioid and using other analgesics. In this case, and in biliary colic, the dose of opioid should be increased. That is to say, if we have used the opioid to manage biliary colic or urethral colic, and we have got worsening of pain that not responded to using hyoscine, we have no another way than increasing the dose of opioid to get a benefit from the analgesic effect of opioid more than that of constricting effect of DANE. In cardiovascular system, there is peripheral vasodilation. And as you know, this decrease in systemic vascular resistance and producing hypotension. At the same time, this can produce pooling of blood to the lower extremity, and we can get a benefit from this effect in cases of pulmonary edema, that the blood volume shifted mainly to the periphery rather than to the lung. And also, most of opioids producing bradycardia. Most of opioids producing bradycardia. Nariman Abid Hassan.
نعم أستاذ.
Most of opioid producing bradycardia except
Pethidine
Afia. Except pethidine.
Produce atropine-like effect.
Very good, very good. Lina Nasir. لينا نصير.
نعم أستاذ.
شنو الاسم الثاني للباثيدين؟ اوكي
ميبريدين.
عافية. ميبريدين. شنو الفرق بين الميبريدين والباثيدين؟
يعني ما
هبة جاسم. هبة جاسم. هبة جاسم. عمر صلاح.
نعم أستاذ.
شنو الفرق بين الميبريدين والباثيدين؟
أستاذ العفو، يعني أسماء، واحد بريطاني وواحد إنجليزي أمريكي،
ياهو
يعني أمريكي وإنجليزي.
ياهو الامريكي وياهو الانجليزي.
البريدين هو الأمريكي والبيثيدين هو الإنجليزي.
Very good. قبل كم يوم كنت بمناقشة، يعني مو بالأنستيزيا in other branches، وكانوا يحكون على الباثيدين. فأحد المناقشين كان عنده فد رأي أنه الباثيدين هو الاسم العلمي والميبريدين هو الاسم التجاري. Actually, this is wrong. Both of them are scientific names, but one of them, Meperidine, American, and Pethidine, British. So if you read in American textbook, you will never see the Pethidine, all the names as Meperidine. If you read a British textbook, you will see only Pethidine, no use of Meperidine. Others effect. Okay, synergistic hypotensive effect, another effect of the cardiovascular system, and other effects. Chest wall rigidity can be produced mostly by fentanyl, remifentanil, sufentanil, alfentanil, and skin rash. Precautions in the using of opioids. Patient with hepatic and renal disease, because the metabolism of these mostly through hepatic enzymes and excreted through renal system. Patient with respiratory disease because of respiratory depression via central nervous system. Patient with head injury can produce hypnosis, convulsion, allergy, drug interaction. We have two important terms stick to the opioids. These are tolerance and physical dependence. Tolerance, a gradual loss in drug effectiveness. And you have know that tolerance need to increase the dose with the more using of the drug to get the desired original effect. The physical dependence occurrence of withdrawal abstinence syndrome when the drug is stopped or an antagonist is administered. In these two important circumstances, there will be withdrawal syndrome, appearance of several signs and symptoms. Tolerance begins with the first dose of an opioid and can be detected within 12 to 14 hours of morphine administration. Within 3 days, the equianalgesic dose is increased 5-fold. يعني إذا كنا نعطيه for example 10 ملغ راح نحتاج after 3 days to 50 ملغ. The degree of tolerance may be up to 35 folds. ممكن نصعد إلى 35 ضعف. 60 ملغ of morphine causes respiratory arrest in a non-tolerant person. يعني هسه احنا اي واحد من عندنا اذا ننطيه 60 ملغ of morphine راح يصير عنده non-tolerant، راح يصير عنده respiratory arrest. Why? Because we are non-tolerant persons. فلذلك ماكو واحد يستخدم 60 ملغ. احنا هسه in our daily practice ممكن نوصل in incremental doses ل 15. I'm talking clinically. While in addicts, 2000 milligram of morphine may not produce respiratory depression. يعني ممكن تعطي 2000 ملغ وهو ما عنده respiratory depression. Tissue tolerance means some tissues do not get tolerance. يعني some tissue affected by tolerance مثل ما قلنا. For example, the breathing, respiratory system, euphoria, affected by tolerance. So we have to increase the dose. CNS develops to tolerance, but GIT constipation and eye pinpoint pupils do not develop tolerance. If these effects do not develop tolerance, means the patient will complain of constipation and has pinpoint pupils. Why? Because the increasing effect of the opioid affect these functions more than others already develop a tolerance to the opioids. The high tolerance to analgesia, euphoria, dysphoria, mental clouding, respiratory depression, sedation, nausea, vomiting, cough suppression, antidiuresis, while no tolerance to the meiosis, constipation, and convulsions. So the patient with tolerance can develop convulsion as a side effect. The mechanism of tolerance, if you remember in the presentation of general pharmacology, at that presentation we have talked about pharmacodynamic and pharmacokinetic tolerance. Here the tolerance is not pharmacokinetic, but due to the true cellular adaptive pharmacodynamic response. Two proposed mechanisms for the tolerance: one, upregulation of cyclic AMP system. Second, down-regulation of the immune receptor. Down-regulation of the immune receptor. Norcarin. Norcarin. سيف العبيدي.
نعم أستاذ.
سيف يفضل تكتب اسمك الثلاثي حتى أحفظه، لأن العبيدي أكيد ما راح تنزل باسمك الامتحاني فما حفظك. شو اسمه أبو جدك؟
سيف عبد الهادي صالح.
سيف عبد الهادي. What the meaning of down regulation of receptor, Saif?
continuous activation.
Okay, safe. Recent research suggests tolerance results due to uncoupling between immune receptor and G proteins, leading to reversal of second messenger cyclic AMP and ion channel system. Tolerance to the sedating and respiratory effects dissipates within a few days after the drug is discontinued. إذا وقفنا الدراج برا كم يوم بعد هاي التولرانس تنتهي ونرجع لازم نعطي smaller doses. Now regarding the cross tolerance, does the tolerance affect other types of opioid in response to tolerance of specific certain opioid? Patient tolerant to morphine show a reduction in analgesic response to other agonist opioids. So the cross tolerance occurs between drugs acting at the same receptor, but not a drug acting on different receptors, and occurs for analgesic, euphoriants, sedative, and respiratory effects. Dependence compromises two important components. First, physical dependence associated with withdrawal symptoms and lasting for a few days. After the few days, there will be abolishment of the sign and symptom regarding the withdrawal syndrome. So it is a matter of patience for a few days of suffering, I mean. While the psychological dependence associated with craving lasting for months or years. And this is very important, that the psychological dependence more important and most severe complaint than that of physical dependence, because this psychological dependence may extend it for months or years, and this may be the real cause of return back to the using of opioid again after stopping and curing. For the psychological dependence, opioids facilitate dopamine transmission in mesolimbic, mesocortical pathway and activate endogenous reward pathway in the brain. Important in initiating and maintaining drug-seeking behaviors. Psychological dependence rarely occur in patients being given opioids as analgesics. That is to say, psychological dependence not occur in those patients that we are dealing with them and giving them opioids for the analgesic purpose, while the psychological dependence is the main cause of dependence for those patients who have been taking the opioids for euphoric effect. The manifestations of withdrawal syndrome are rhinorrhea, lacrimation, yawning, chills, piloerection, hyperventilation, hyperthermia, mydriasis, muscular aches, vomiting, diarrhea, and anxiety and hostility العدائية. تحسه عدواني. Signs of withdrawal syndrome start within 6 to 10 hours after the last dose. And this is very short time. After 6 to 10 hours, the signs and symptoms starts. The peak effects are seen at 36 to 48 hours. By 5 days, most of the effects have disappeared, but some may persist for months. The methadone used to manage those patients. Several days are required to reach the peak effects, of methadone. It may last as long as 2 weeks. After the abstinence syndrome subsides, tolerance also disappears. Craving for opioid may persist for many months. How to treat morphine dependence? Substitute an agonist. يعني نبدل الدواء اللي هو دا ياخذه. إذا كان ياخذ مورفين نبدله. ايش نعطي؟ نعطي another one with following properties. First, less potent than original drug. Second, with longer duration of action. ثلاثة, easier withdrawing. It will give similar pleasure, but withdrawing the drug will be easier due to long duration of action. Withdrawal symptoms will be less severe. So the methadone of long duration of action or buprenorphine with mild withdrawal effect regarded as the drugs of choice to manage morphine dependence. The antagonist can precipitate the withdrawal signs and symptoms. Induced in subject physically dependent on opioids by administration opioid antagonists like the naloxone. Within 3 minutes after injection of the antagonist, full-blown withdrawal syndrome appears, peaking in 10 to 20 minutes and subsiding after 1 hour. Even in the case of methadone, the antagonist precipitated abstinence syndrome may be very severe. Why? Because there is abrupt antagonism of all the effects of antagonist. So there will be no benefit from the property of long duration of action of methadone. So even if with methadone, the antagonist precipitated abstinence syndrome may be very severe. Detoxification of addict by using low dose of methadone, 5 to 10 milligram orally, are given 2 or 3 times daily for 2 to 3 days. Upon discontinuing methadone, the addict experiences a mild withdrawal syndrome. For maintenance therapy of the opioids, recidivist tolerance to 50 to 100 milligram per day of oral methadone is produced. In this state, the addict experiences cross tolerance to heroin. Heroin is the main drug used in the maluse of opioids for addiction that prevents most of the addiction reinforcing effects of heroin. We have another topic, acute morphine poisoning. That is to say, the use of morphine in large doses for suicidal attack or accidentally or for any reason, how can we manage? 50 milligram morphine IM produces serious toxicity. Lethal dose of morphine 250 milligram. Manifestations are extension of pharmacological effect like stupor, flaccidity, shallow breathing, cyanosis, meiosis, decreased blood pressure, and shock status. And regarding CNS, there may be convulsion. Pulmonary edema, coma occur at terminal stages. Death is due to respiratory failure. The treatment by mainly respiratory support, خليه artificial ventilation, endotracheal tube and artificial ventilation. Maintenance of blood pressure, that is to say using of fluid, vasopressors. And if the route of administration was oral, we can get a benefit of gastric lavage with potassium permanganate. We can get a benefit of an antagonist like naloxone, the using of 0.4 to 0.8 milligram intravenous repeated every 2 to 3 minutes till respiration pick up. Repeat the dose every 1 to 4 hours, mainly every 2 hours later on, according to response. Preferred specific antagonist does not have any agonist effect and respiratory depression. Naloxone has a short duration of action, about 1 to 2 hours. So a depressed patient may recover after single dose of naloxone and appear normal, but relapses into coma after 1 to 2 hours. So we have to give another dose after each 1 to 2 hours till ending the effect of the original agonist. Addicted neonates. For those mothers already taking drugs during pregnancy, the fetus may become physically dependent in utero. Withdrawal signs are seen in the early postpartum periods. A daily dose as small as 6 milligrams of heroin taken by the mother will result in a mild withdrawal syndrome in the infant. Twice that dose may result in irritability, shrill crying, diarrhea, or even seizure. Regarding the routes of administration of opioid, can be oral, parenteral, transdermal, neuroaxial, rectal, transmucosal. And we have endogenous opioids in our body, named as endorphin, enkephalin, dinorphins. Now we will focus on most important opioids one by one. Now we are talking about morphine per se. It is a gold standard for opioids. It is hydrophilic, شيماء مظفر.
نعم أستاذ.
What does it mean hydrophilic?
Affinity to water, يعني soluble in water.
Good. Soluble in water, not in lipid.
Yes.
Not lipophilic, hydrophilic. So only small amount cross blood-brain barrier, not like that of lipophilic. The half-life is 2 to 3 hours, act at a mu receptor in the spinal cord, inhibits substance P release, substance P responsible for the sensation of pain. So the inhibition of substance P release producing analgesic effect. Morphine 6-glucuronide, more potent than the parent drug regarding the analgesia. It is a metabolite of the morphine, while morphine 3-glucuronide has a neuroexcitatory effect. So caution should be taken in patients with renal failure because there will be an increase the amount of this metabolite, reducing, for example, convulsion. Pharmacological action of morphine: analgesia, respiratory depression, cough suppression, vagal stimulation producing bradycardia, sedation, hypnosis, hypothermia, itching, physical and psychological dependence, euphoria, histamine release, hypotension. The adverse effect: morphine can produce a wide range of adverse effects like nausea, vomiting, dizziness, mental clouding, respiratory depression, constipation, dysphoria, urinary retention, hypotension, and allergic reactions. The tolerance to morphine: repeated administration of morphine results in the development of tolerance to some of its effects, including respiratory depression, analgesia, sedation. Dependence: opium has been a drug of addiction for many centuries. Its ability to produce euphoria make it a drug of addiction. Opioids produce both physiological and psychological dependence. Manifestations are lacrimation, sweating, yawning, anxiety, and restlessness. Another drug, diomorphine. Diomorphine is better name than heroin because heroin related to abuse of the opioids, while diomorphine is a better scientific use during medical indication of the diomorphine. Diomorphine crosses the blood-brain barrier more rapidly than morphine, 2 to 4 times greater potency than morphine, and it is converted to morphine to produce its action. زينة خليل.
نعم أستاذ.
What does it mean to for greater potency than morphine?
أستاذ يعني الدوز أقل يعني
Good.
to produce the same effect.
Good زينة. سارة حسن.
نعم أستاذ.
Do you know if the diomorphine has important role in our daily practice as an anesthetist or not؟ يعني الدايمورفين تعتقدين انه يستخدم هوايه لو قليل اوفج من العراق، خلينا نقول حتى خارج العراق؟
والله ما عندي معلومة، بس هنا لا ما شايفين.
ما عندك معلومات. No problem. Diomorphine is the most commonly drug used in clinical practice. يعني مثلا خارج العراق I have seen in Britain using the diomorphine routinely combined with the bupivacaine for spinal anesthesia during cesarean section. فدائما يستخدموه أسباب استخدامه أولاً long duration of effect، ثانياً less side effect than that of morphine، فلذلك يستخدموه كلش هواية in combination with the bupivacaine in spinal anesthesia، فيمتد شغله لمدة 12-14 ساعة post operatively، يعني after the ending of the duration of effect of bupivacaine يبقى الإفكت of diomorphine. طبعا العراقيين رادوا يقلدون هذا الموضوع، فقاموا شو يسوون؟ يستخدمون الفنتانيل يخطوه ويا الماركين ويسوون سباينال انستيزيا. فتسأله ليش؟ يقول لك I want to get more solid drug, a more solid anesthesia. بالحقيقة هو ماكو solid anesthesia over the use of local anesthetic. يعني إذا واحد استخدم اللوكال anesthetic ويسوي paralysis بعد شنو solid anesthesia؟ هو paralysis صار، يعني اكو اكثر من الباراليسيس، هو باراليسيس صار، فشنو اللي تطلبه بعد؟ هم برا من يستخدمون الدايومورفين. The justification for this use is the long duration of effect and the patient can get a benefit post-operatively from the analgesic effect of diomorphine for about 12 to 16 hours. Hydromorphine, about 8 to 10 time potency of morphine, more potent than the morphine, slightly shorter duration than morphine, available as suppository. Codeine, we have talked about codeine in the general pharmacology presentation. It has about 1/10 the potency of morphine, فالدوز مالته تكون أعلى, has lower efficacy than morphine, just 10% converted to morphine by the enzyme known as CIP 450 to D6. 10% of patients do not possess this enzyme. So if we give codeine and there is no analgesic effect, means that the patient is one of those 10% has no such a conversion of morphine of codeine to morphine to produce its analgesic effect. Has less antitussive effect than morphine. Check older men to avoid prostatic hypertrophy, avoid the urine retention. There is less risk of abuse than morphine. Oxycodone, about 10 time potency of codeine, also metabolized by the same enzyme, controlled release formulation, oxycontin. Niperidine, قلنا البethidine, about 1/8 potency of the morphine, معناها يحتاج نعطي دوز أعلى, shorter duration than that of morphine, binds to kappa receptor, causes respiratory depression, pupillary dilatation, opposite to that of morphine, that producing meiosis rather than pupillary mydriasis. And in page GIT motility, fewer smooth muscle spasm than morphine, no meiosis at usual dose, but will with overdose. إذا نستخدم الأوفردوز يتحول لpupil dilatation إلى meiosis. Little or no anti-diarrheal or antitussive effect. It has atropine-like effect, لذلك producing tachycardia, to be considered in patients with ischemic heart disease, patient with dysrhythmia, elderly patient, because this tachycardia may increase the O2 consumption and trigger a new attack of ischemic heart disease. And also has quinidine-like effect, which is a membrane stabilizing that prevent or antagonize the dysrhythmias. It can partially inhibit catecholamine reuptake into presynaptic neurons, and for this reason, if patient already on MAO inhibitor, may cause severe hypertension and coma. Why? لأن راح يصير عندنا more reuptaking of catecholamine, more amount of noradrenaline and adrenaline in the circulation, causes shooting of blood pressure and may causing coma. So not to be given in patient already on MAO inhibitors. Fentanyl is that a drug with 80 to 100 potency of the morphine. It is very fast in onset of action, but has short duration. Used intravenous for anesthesia and available as patch and available as oral slow release devices. سارة مزاحم.
نعم أستاذ.
سارة هنا
نعم
يقول
أستاذ.
fentanyl available as patch, and I have seen that fentanyl patch before. Do you prefer using fentanyl as a patch or not, and why?
ما أدري.
Okay, thank you سارة. الحقيقة هذا الفنتانيل باتش سووه لغرض المانجمنت of patient with pain due to CA as a part of palliative pain management. يعني هذا يوصل مرحلة المريض انه خلص راح يموت، فنريد يعني ما نخليه يحس بالألم آخر أيامه، فيستخدمون الفنتانيل باتش يعني for continuous supplement of analgesia. احنا هنا بالعراق ما يدرون شنو السالفه، فد يوم من الايام واذا تجينا فد شفته كبيره من الفنتانيل باتشز استخدموه بالعمليات. طبعا اذا نستخدمه بالعمليات لازم نعرف هسه الايفكت مالته شنو هذا. الفنتانيل باتش كان اكو منه يعني 3 دوزز، واحد 100 مايكروغرام اللي هو جابوا لنا اياه، واحد 50 ملغرام، واحد 25 ملغرام. احنا جابوا لنا ابو ال 100 مايكروغرام. 100 مايكروغرام means انه هاي الباتش deliver fentanyl in about 100 مايكروغرام each hour. واذا بقيتها 3 ايام ممكن تبقى 3 ايام كل ساعة تعطيك 100 microgram of fentanyl. فكان you imagine the exaggerated side effect of fentanyl with such a patch. فاحنا طبعا خو ما نذبه هذا، ما نذبه، فحذرنا الموجودين انه ممكن تستخدموه بالعملية مثل ما انت تعطي بالعملية. يعني عادة تعطي خلينا نقول 100 مايكروغرام of fentanyl، فايش قد تريد تعطي؟ 100 شيلها ببرا ساعة، 200 شيلها ببرا ساعتين. واهم شيء حذرناهم انه المريض من يطلع المريض لازم تشيلوها، لانه اذا ما شلتوها راح تسوي لنا very exaggerated side effect.
نعم أستاذ.
قد واحد منكم يقول لا عاد شنو المشكله خو خلينا نستخدمه بهاي الطريقه. المشكله انه هذا طبعا بما انه هو مخصص for treatment of patient with CA pain، فيعطي يعني large doses over 3 days، معناه هذا expensive. فالخساره اللي صارت هي خساره كوست، يعني فشي مخصص ل3 ايام احنا قمنا نستخدمه لساعه او ساعتين وندبه. طبعا ايضا اخترعنا طريقه جديده، طريقه عراقيه not scientific. كنا الكيسات اللي نريد لهم دوزز اقل كنا نقصها، هاي الباتش نقصها حتى تعطي اقل دوزز، تعطي 50 او ونلزقها ببلاستر تعطي 50 او 25. فبليز افويد ات. اذا في اليوم خرجتوا صرتوا باللجان الاستشاريه ويقولوا لكم انتم بدون باتشز، عرفوا انه الباتشز تستخدم لامراض الاورام as a part of palliative pain management rather than the use of fentanyl intra or post operatively. Remifentanil, it is approximately twice as potent as fentanyl and 1 to 200 times as potent as morphine. It has rapid onset and very short, ultra short duration. Metabolized by non-specific plasma and tissue esterase, and this is very important property of remifentanil that can be used safely in patients with renal failure, heart failure, liver failure, can be used freely without side effect. Can be administered as a part of an anesthesia technique called TIVA. TIVA means total intravenous anesthesia, the use of intravenous anesthesia without the use of inhalational anesthesia, totally intravenous anesthesia. This is in combination of remifentanil and propofol with or without muscle relaxant. It is also used for sedation as well as combined with other medications for general anesthesia due to synergism with various hypnotic drugs and volatile anesthetics. It is a good choice in controlled hypertension technique. Previously, we have to use many hypotensive agents to produce controlled hypotension. After the using of remifentanil, there may be no need for further use of more hypotensive agents because the remifentanil can produce efficient hypotension suitable for controlled hypertension technique. Stop infusion lead to hyperalgesia. Hyperalgesia means exaggerated pain sensation in response to ordinary stimuli, pain stimulation, reasonably to be preceded by giving another analgesics. That is to say, to give another analgesics before stopping the infusion of remifentanil. Also, the remifentanil has important and serious side effects, can cause a reduction in sympathetic nervous system tone that include dose-dependent decrease in heart rate and arterial blood pressure and respiratory rate and tidal volume. Generally, there will be a hypotension and respiratory hypoventilation or respiratory arrest according to the dose. Its use mandates strict monitoring. Please don't use remifentanil without strict monitoring. And this strict monitoring does not mean only the use of monitors like blood pressure, pulse rate. I mean by strict monitoring by the personnel. There should be somebody beside the patients whenever you use remifentanil, continuously to stand beside the patient and monitor the blood pressure, pulse rate, and the breathing. Muscle rigidity is sometimes noted. Better to be avoided in spontaneously breathing patient, but it has been used for analgesia in labor successfully in well-setted environment. يعني يحتاج لفد مكان يكون السيتنج مالته precise setting with good monitoring to avoid the side effects that may lead to morbidity and mortality that overcome the benefit of the use in remifentanil. The dose of remifentanil during anesthesia, the induction 0.5 to 1 microgram per kg per minute IV until after intubation, and may give initial dose, bolus dose of 1 microgram per kg if intubation to occur less than 8 minutes after start or infusion. And for the maintenance of anesthesia, 0.25 to 0.5 microgram per kg per minute IV, and may bolus with 0.5 to 1 microgram per kg, 2 to 5 minutes in response to light anesthesia or transient episodes of intense surgical stress. Also used in conscious sedation in a dose of 1 microgram per kg IV, followed by 0.05 to 0.2 microgram per kg per minute IV. Analgesia, for analgesia, immediate post-operative period, 0.025 to 0.2 microgram per kg per minute IV. And always use lower dose and look at the effect, and after seeing the effect, you can increase or decrease according to the gating effect. Methadone, potency of methadone similar to that of morphine for intravenous administration, but 4 and more potent orally. When using orally, يكون 4 times more potent than that of morphine. It has long plasma half-life, and for this property, it is the good choice to manage patients addicted on opioids. Used in the treatment of narcotic dependence, the duration of action increases with repeated use. Propoxyphene, the potency compared to codeine, potency compared to placebo, again, produces cardiotoxicity and pulmonary edema, and its active metabolite produces convulsion. Now we are talking about mixed agonist antagonists. And these are nalorphine and cyclazocine, bentazocine, butorphanol, and nalbuphine. These are 5 well-known mixed agonist antagonists. Bentazocine agonist for kappa receptor, so producing some of opioid receptors, antagonists for mu delta receptors. So it is indicated for moderate pain. For severe pain, we have to use pure agonist. For moderate pain, we can't get a benefit of mixed agonist-antagonist. Produces less euphoria. Butorphanol is also GABA receptor agonist, receptor antagonist, also available as nasal spray, has 5 times potency in women than men. Gender differences in GABA opioid receptor effects were observed, producing significantly greater analgesia in women than in men. This appeared to be dependent on the drug examined, and here there is a link if you want to get more information about this issue. Nalorphine and cyclazocine, both are GABA receptor agonist, mu receptor antagonist, produce psychomimetic effect, produce dysphoria. Nalbuphine, GABA receptor agonist, mu receptor antagonist, little dysphoria compared to nalorphine and less abuse potential than morphine. Regarding the opioid antagonist, we have famous one, naloxone, and second, naltrexone, and third, nalmefene. The naloxone has a short half-life, not effective orally, 0.4 to be dissolved in 10 ml normal saline, and administered 1 to 2 ml every 1 to 2 minutes. That is to say, 1 ampoule diluted to 10 ml, and we can use incremental doses of 1 to 2 ml looking at the response every 1 to 2 minutes. Naltrexone has long half-life, effective orally or injected, used for treatment of dependence. Intermediate duration with nalmefene, 4 to 6 hours, orally active, no hepatotoxicity with long-term use. Here, the important agonist and the dose related to newborn or children, and according to the indication, for example, in ICU, in surgery, just for your attention. What's the role of opioid in chronic pain management? Ali Hussein Ali.
I'm still.
What is the role of opioid in the management of patients with chronic pain?
I think little role for opioid because of several side effects and because of dependency.
Good. You can use opioid just in 2 situations for patients with chronic pain. First one, as a part of palliative pain management, يعني واحد هو خلاص يعني and a non-curable cause of pain and gonna to be died, فنستخدم له opioid, and we don't care regarding the addiction and the dependence, physical or psychological dependence, لأن هو الموضوع منتهي. This is the first indication. The second indication, those with chronic pain, but presented for several acute on chronic attack. يعني هو chronic pain احنا ما نعطي opioids بس يجينا in acute attack, acute on chronic تطول لها فد 3-4 ايام. فبهاي 3-4 ايام if we fail to manage acute pain by the non-opioid analgesics, we can use the opioid in such circumstances for a short duration of effect. Now we're gonna talk about ketamine. Which of the following statements are correct? في الحقيقة all of them are correct. Ketamine was first released for clinical use in 1970 after being used during the Vietnam conflict. Ketamine is a phencyclidine derivative. Ketamine is a potent analgesic. Ketamine has a number of adverse psychological effects. Ketamine affects opioid tolerance and hyperalgesia. Ketamine consists of two isomers, R and S, the latter of which is more potent. All these statements are correct. The mechanism of action of ketamine is by non-competitive antagonism of NMDA receptor. NMDA receptor. Ahmed Abbas.
نعم أستاذ.
What does it mean non-competitive antagonism?
أستاذ يعني ماكو شيء إنه ممكن يعني شلون إنه يكون بمكانه، يعني ياخذ السايت اللي مرتبط به ويا الأنمثل دي أسبارتيت.
Okay, Ahmed.
نعم أستاذ.
Also has an effect by binding opioid receptor, mu receptor. Antagonism at cholinergic receptors, which are either nicotinic or muscarinic. The effect on nicotinic receptor producing behavioral changes, and on muscarinic receptor producing the bronchodilation and increase the heart rate. Pharmacodynamics effect on CNS increase intracranial pressure, but preserving the cerebral autoregulation has no effect on cerebral autoregulation. On the cardiovascular system has important direct myocardial depression, but indirect myocardial stimulation by increase the sympathomimetic outflow. So the increase the sympathomimetic outflow means increase the adrenaline, noradrenaline that affect the heart to increase myocardial contraction, increase heart rate, increase systemic vascular resistance, opposite to the main direct myocardial depression effect. Actually, the predominant effect, not the direct effect, it is the indirect effect. So the net result of the effect on the cardiovascular system is the increase in heart rate and blood pressure. The only situation that may result in the dominance of the direct myocardial depression when the patient presented with exhaustion and with the using of all the sympathomimetics that lead to disappearance of the indirect myocardial effect and the appearance of direct myocardial depression, and I think this is very rare situation. Another cardiovascular system effect preserve the baroreceptor reflexes. The baroreceptor reflexes. علي ناظم.
نعم أستاذ.
baroreceptor reflex.
أستاذ الريسبتر اللي موجودة يعني بالكاروتيد ساينس اللي تكون مسؤولة عن التشينج بالبلد بريشر.
Good. Good. The effect on renal system maintain renal blood flow compared to propofol. And there are new clinical uses in sub-anesthetic doses. It has good analgesic and sedative properties. And there is new talk about the effect on immune function and about the uses in pediatrics. It has been observed significant reduction in leukocytic activation precipitated by hypoxia or sepsis, and suppression of pro-inflammatory cytokine production in human whole blood in vitro. So this may lead to talk about the possibility of the effect on immune function of the body by the using of ketamine. Regarding the pediatric uses, least hemodynamic effects, and so can be used in patients with congenital heart disease with no change in pulmonary artery pressure or pulmonary vascular resistance, and for pain control and sedation in critically ill patients and status asthmaticus. Perioperative pain management, the mechanism of antinociception, the role of ketamine to prevent the wind-up phenomenon. Wind-up means increasing the sensation of pain by several mechanisms, preventing opioid tolerance, decrease in activity of brain structures responding to noxious stimuli. أمير الحكيم.
بل أستاذ اسمع.
How can ketamine prevent opioid tolerance?
أستاذ هي بالسب أنستيك دوز يعني نقدر نستخدمه؟
Whatever. How can prevent opioid tolerance?
هو انتاجونايزنج للإفكت مالته يعني دائما احنا ننطي وياه يعني على مود السايد إفكت هذا اللي.
Okay, thank you, Amir. And a few slides before, I have talked that the tolerance can be prevented by using of an NMDA antagonist, and the ketamine is the famous NMDA antagonist. So the using of ketamine with opioid decreasing the tolerance effect of opioids. Dosing schedule of ketamine, intravenous ketamine as an analgesic adjuvant to general anesthesia. First dose should be administered before skin incision, before or after induction. And this is what we call preemptive analgesia, the use of analgesic before the first surgical stimuli. We can use the ketamine in painful procedure 0.5 milligram per kg, slowly bolus IV. Then every 30 minutes, 0.25 milligram per kg, every 30 minutes, or 0.5 milligram per kg every 1 hour. If the procedure more than 2 hours, stop 1 hour before the wound closure. Stop it. In less painful procedure, half the above dose, starting by 0.25 milligram per kg slowly IV, then either 0.125 milligram per kg at 30 minutes interval, or 0.25 milligram per kg every hour. I used to use ketamine in such a dose, 0.5 milligram per kg, in all my general anesthesia, unless there is contraindication for the use of ketamine. I used to use routinely the ketamine during the induction of general anesthesia in every patient unless there is a contraindication for the use of ketamine. So it is very important to be included in your daily practice of general anesthesia. There is S-ketamine isomer, which has a 4-fold greater binding affinity to the NAMDA receptor than that of the racemic mixture. S-isomer has the following properties. It is more potent, shorter duration, and less emergent recovery. Unfortunately, I haven't seen or used this isomer till now, and I haven't seen it even in the outside Iraq. Maybe available, but I haven't seen it at all. Studies regarding this isomer, single bolus decrease opioid requirement in 7 out of 11 patients, continuous infusion, IV, and epidural, decrease the IV and epidural opioid in 6 out of 11 patients. By using PCA, patient control analgesia, no improvement of analgesia over opioid alone, and the epidural, using of ketamine epidurally, 5 out of 8 showed beneficial effect, and in children, ketamine showed beneficial effect. Conclusion of the systemic review, small dose ketamine was useful in 54% of studies. Ketamine should be considered as an additive in the surgical population with large opioid requirement. Small dose ketamine was not associated with increased psychomimetic effects. And for sedation, small dose ketamine with propofol led to a faster onset and better quality of sedation in elderly patients exposed to retrobulbar block with less side effects. Limitation to its use. Psychomimetic effect could be minimized by the dose less than 1.5 milligram per kg, means the total dose. Use propofol or midazolam with it, using of S-isomer. Thank you very much. If you have any question or comment, I'm happy to hear from you.
أستاذ عفوا بس على مدري راميفنتانين
راميفنتانين
على الهايبرالجيسيا وننطي يكون ايه ذوي له نوقف الدوز مالته.
شلون؟
هذا كل الدوزز مال راميفنتانين حتى لو
السؤال شنو بالضبط؟
العفو دكتور على مود الهايبرالجيسيا
هايبر
راميفنتانيل هايبرالجيسيا.
يس
اي
يس
قلنا كنا نعطي انالجيسيك قبل ما نوقفه. احنا يعني بس بالانفيوجن هاي نسويها، يعني بس بالتيبا لو بكل الدوزز اللي نعطيها مال راميفنتانيل ممكن تصير عندنا.
هو احنا شو وقت نستخدم الراميفنتانيل؟ نستخدمه اثناء العمليه for intraoperative analgesia whether it is part of TIVA or not. مو صحيح؟ ممكن part of TIVA or not part of TIVA، بس نستخدمه as intraoperative analgesia. مو صحيح؟ مو صحيح؟ وياي؟
وياك دكتور.
زين، بنهايه العمليه شو نسوي احنا؟ المفروض نسوي نسد الفنتانيل. من راح نسد الفنتانيل نتوقع هايبر الجيسيا. فاحنا قبل ما نسد الفنتانيل شو نسوي؟ العفو، رمي فنتانيل. I'm talking about رمي فنتانيل. قبل ما نسد الرمي فنتانيل نوقف الانفيوجن، نعطي فور اكزامبل ترامادول، نعطي حسب يعني السيفيريتي of expected post-operative pain اللي هو ممكن يكون mild, moderate, severe according to the type of surgery. ممكن أعطي نان ستيرويدال كيتورolac فولترين، ممكن أعطي باراسيتامول، ممكن أعطي ترامادول، ممكن أعطي opioids according to my expectation regarding the severity of post-operative pain.
اوكي.
واو.
زين دكتور، سؤال ثاني. انا مود الكيتامين سكيدول، دوزنج سكيدول مالته يعني اذا الكيتامين وحده كانالجيسيك، لو حتى لو وياه شيء ثاني احنا بدنا نعطي انالجيسيك سواء فنتانيل او
ما فهمت سؤالك.
الدوزنج سكيدول اوف كيتامين.
نعم.
يعني هذا اذا ننطي وحده كانالجيسيك كانترا اوب، هاي الدوز مالته لو حتى لو وياه انالجيسيك ثاني سواء فنتانيل او شيء ثاني.
أنا بالنسبة لي أستخدمه وحده without addition of other analgesics. بس إذا حالات معينة أنت حسيتي for any reason إنه هاي الدوز not enough, you can add another analgesics like fentanyl for example.
شكرا.
بس أنا بالنسبة لي أستخدمه وحده. يعني مثلا بالسيزيريان سكشن أنطي at induction تقريبا 35 ملغرام اللي هي 0.5 ملغرام بير كي جي، وبعد حتى من يطلع البيبي حتى فنتانيل ما انطي، وما احتاج ان انطي فنتانيل، بس انطي باراسيتامول، وانطي اذا متوفر اكيوبان for post operative، انطي انترا اوب for post operative pain relief.
تمام استاذ، شكرا جزيلا.
ممكن سؤال ثاني؟
تفضل.
بالديتوكسيفيكيشن مال ان ادكت بنستخدم الميثادون بالمينتنس ثيرابي يصير عنده توليرانس لما نستخدمه اورالي 50 to 100 ملي جرام.
الميثادون تحكين؟
الميثادون detoxification of an addict.
اوكي. شنو سؤالك؟
السؤال يعني هو لما استخدمه
هاي
استخدمناه الميثادون، هي لما استخدمناه maintenance therapy.
نعم.
قلت يصير عنده tolerance للميثادون بالمينتنس ثيرابي، يصير عنده tolerance للأورال ميثادون. شنو قصدك هاي كروس؟ هذا الستيت يصير كروس tolerance to heroin prevents most of addiction. ما فهمتها. يعني بعدين يصير كروس tolerance للهيروين ورا ما نستخدم المينتنس ثيرابي مال الميثادون.
يعني
آخر عبارة، آخر سطرين.
يعني in this state the addict experiences cross tolerance to heroin. يعني إذا صار عنده نستخدم هيروين بعدين إذا ردنا، يعني هو احنا المفروض ما نستخدم هيروين بعدين، فنقول هو البيشنت إذا راد يستخدم هيروين بعدين فهنا
tolerance يمكن.
نعم.
احنا استخدمنا الميثادون كعلاج لما صار عنده tolerance للميثادون يعني وراها تستخدم هيروين؟
احنا استخدمنا الميثادون كعلاج للهيروين، يعني المفروض بعد ما
كعلاج.
لكن خلينا نفرض انه المريض اراد يستخدم هيروين، بهاي الحاله
تمام
يحتاج لشنو؟ يحتاج لهاير دوز. هذا معنى.
اوكي شكرا. شكرا استاذ.
عفوا. اكو بعد سؤال؟ اوكي اذا ما عندكم سؤال ثانك يو فيري ماتش اند جود باي.
شكرا جزيلا.
شكرا
جزيلا
أستاذ.
استاذنا العزيز.
شكرا جزيلا أستاذ.
شكرا جزيلا استاذ.